My topic will be indications of occipitocervical fixation. Actually, I want to promote also the Craniovertebral Junction and Spine Society. On the left-hand side, it is the logo of the society and the website of the society. This is craniovertebral.org is the website. Our chairman is Atul Goyal from India. And there is one journal called Journal of Craniovertebral Junction and Spine. My presentation order will be like this. Is there a problem of occipitocervical fixation? Then I will tell something about the complications and technical evolution, indications, technical consideration, and conclusions. Is there a problem? Yes. I believe that there are many unnecessary occipitocervical fixations. Many cases with C1, C2 instability only have traditionally gone to occiput C1, C2, even lower cervical fixations. And occipitocervical fixations significantly restrict head movements, and it has a very high non-union rate. In fact, the occipitoaxial joint is a very strong joint. The strength of the ligaments and the orientation of the joint surface provide remarkable stability. However, in most of the cases in this region, the instability is not at the occipitoaxial joint, but it is in the atlantoaxial joint. Especially it is true with basilar invagination cases. What are the complications of that approach? Very commonly, our occipital screws may penetrate the dura and cause CSF fissura. It may even cause some cerebellar hematoma, and hardware-related complications are quite often, like screw loosening, pseudoarthrosis, instrument breakage. And one report from Vaccaro from 2010 has mentioned about 50% pseudoarthrosis rate. Infection may also be a problem. Non-union is quite often if the allografts are used, if the bone quality is not good, and if there are severe deformities, the cases with hyperlordosis. This is a case of our group with bilateral fracture of the rods after a non-union of occipitocervical fixation. This is a also odontoideum case. Although we have done a C1, C2 fixation, C2 screws are broken. We did a revision surgery, but 3 months later, it was again broken. We launched the surgery till C3. But then C1 screws are broken 1 month later, and we switched then after that to more longer fixation with occiput. In fact, there are rigid and non-rigid fixation techniques. Non-rigid techniques were being used in the past by sublaminar wiring, only bone grafting. But recently we have very good rigid fixation devices, plate or rods. Complication rates with non-union is quite high with non-rigid fused patients. Technical evolution of the occipitocervical fixation historically have come from long fixations, application to all craniocervical pathologies without reduction, and recently it has come to an era with shorter fixations, separate indications. Reduction could mostly be achieved by a posterior-only technique. And these are probably the historical cases with Lucas-Herschel rectangle and Ransford loops. And there were even some cases in the past. We were opening the burr holes in the occipital bone and passing wires from that burr holes. This is one of my cases with C2 osteoblastoma. I have operated with a retropharyngeal approach first, then a posterior fixation using such technique with 2 plates and some multi-filament titanium wires. In 1996, I was using such hooks system. Then we switched to Y plates. Then, because in the middle, the occipital bone is thicker, then produce some special designed plates, and we have done such cases with longer fixations. You can see we were going down to mid or lower cervical spine with the occipital plate. But then rod screw systems have been evolved. We now use occipital plates or plate rod designed fixation techniques. These are from recent cases. But in 2004, the techniques have evolved, and we started to doing some shorter fixations with posterior reduction techniques. And this is one of the cases in 2005, rod-based screw fixation. We have done a paper in 2002 using a combined anterior and posterior approach for managing buzzer invagination associated with type 1 Chiari. But the Goel technique has revolutionized the posterior fixations. The pioneering work was from 2004 in the Journal of Neurosurgery Spine. It was by using a C1 lateral mass and C2 pedicle screw fixation and making a posterior reduction by placing a spacer in between C1 and C2 joint. Here you can see one of the cases we have done before and after surgery. We can skip those slides. Functional radiograms, and this is on the left. This is pre-op. On the right, this is post-op films. Yes, this is the spacer, a small cage on one side. We couldn't place the cage on the other side. Yes. Another case, buzzer invagination, shorter fixations. You can see how we changed our techniques from 1996 to 2004 and then 2012. Last generation fixation devices are having plate and polyaxial screws, and we are trying to use not adding occiput to fixation in most of the instances. As I said previously, we turned out from long fixations application to all craniocervical pathologies. We are now making shorter fixations, separate indications. Reduction could mostly be achieved by a posterior only indication. What are the indications of occipitocervical fixation? Absolute indications are traumatic occipitoatlantal instability, occipitoatlantal instability due to buzzer invagination, especially in irreducible cases. And somebody may also consider an adding an occiput if there is an atlas assimilation or dyskinesis of C1 lateral mass and occipital condyles. Besides, tumors and infection at the region and rheumatoid basilar invagination should better be gone to occipitocervical fixation. There are also some relative indications. We don't know for sure if we have to make an occipitocervical fixation or C1, C2 only, like odontoid resections after odontoid resection, Down syndrome and cranial septic, cases with osteoporosis, irreducible rheumatoid atlantoaxial dislocations, complex C1, C2 fracture dislocations, and revision cases. This is one algorithm I can present in case of traumatic upper cervical instability. We must ask first if there is an occipitocervical instability or not. If there is not, all our aim must be focused on C1, C2 fusion only. If it's a non-trauma case, if there is no compression or myelopathy, we can follow the patient. But then we ask again whether there is cervical instability or atlantoaxial instability only. Whether we have to add a traction there, if it is reducible, just C1, C2 fusion, or if it is irreducible, anterior decompression and occiput C1, C2 fusion may be added. What about the technical consideration for this technique? We always do it under prone position with lateral C-arm control, mechanical head to use, reduction with traction we can use, and preoperatively we can measure the thickness of occipital bone with vertebral artery anomalies we must look at. How long shall we go downwards or caudally? We must have a case-based evaluation. Ideal is occiput to C2 or C3, but in some cases like rheumatoid arthritis and severe deformities, we may go downward more levels. Also in some tumor cases, also in some hyperlordotic cases, we can go more caudally. Cases with basilar invagination, when do we have to add occiput to fixation? Although Atul Goyal is saying that all cases are reducible, but it depends on the surgeon's attitude and ability. If not reduced and need odontoid resection, we can make a occiput cervical fixation. If C1 is assimilated, I think the best way is still occiput C2 fixation. In conclusions, there have been two great refinements. One is the posterior reduction of basilar invagination and C1, C2 screw fixation techniques. And occipitocervical fixation restricts head movements and has a very high non-union rate. Unnecessary occipitocervical fixation must be avoided. The main problem is the decision for whether an occiput C1 or C1, C2 instability present. And most cases have only C1, C2 instability, and occipitocervical fixation is not necessary. This is my presentation. And probably in conclusion, for basilar invagination, reducible C1, C2 fixations only. If it is non-reducible or reducible but C1 is assimilated, we can add occiput to our fixation. And and recently necessity of transoral surgeries have decreased a lot. I was doing 50 or more cases in a year, transoral surgeries. Now I'm doing 1 or 2 cases in a year. In case of occipitocervical fixation, shorter fixation must be tried, and we must try also using autographs to avoid non-union. Thank you for listening to me.
Thank you for your presentation. As you mentioned, the necessity of a transoral approach has been reduced. How many percentage of the transoral approach in your institute right now?
Probably we reduced the transoral surgeries more than 90%.
Mm-hmm.
More than 90%, probably we reduced them. As I said, only for some tumors or infections, I'm doing 1 or 2 cases a year. Very low.
For the rheumatoid
arthritis, if you can reduce, I'm using occipitocervical fixation because the bone quality is not good. They are having long-term corticosteroid applications treatment, and so then it's better to make a occipitocervical fixation, not C1, C2 only.
Okay. Any questions from others?
Okay, Professor Zileli, I would like to ask you a question. So just like you say, so if when the C1 assimilated, so how do you think it is the difference between the C2 fixation and the occipital C2 fixation?
It's not much different. Actually, you can also make a C1 screwing, but there is not much difference with because C1 is assimilated. You can either place your screws in the occiput.
Do you think the occipital C2 fixation is more stable or faster than the C1, C2? Because it's a 3 point.
At least it's easier. At least it's easier.
Only
actually,
easier, right?
I don't know the numbers, but in case of C1 assimilation, the variations of the artery and the lateral masses are quite often than normal C1.
Okay. Thank you.
Hello.
Okay. So,
can I ask a question? Professor Zileli,
yeah.
If you have lower cervical spine scoliosis, let's say also, this makes you to include occipit in your construct or not? Nothing related with
it. In which cases trauma? Sorry?
In degenerative cases or basilar invagination or whatever, that you have some sort of subaxial scoliosis?
No, it's quite rare. Actually, in some deformities, cervical deformities, you may need to include it. I have recently I haven't seen any osteoporotic fracture in the cervical spine, but recently I've seen one case of osteoporotic fracture at C6 and T1. In that case, and the patient has a head drop, I used occipitocervical till thoracic spine fixation. In deformity cases, you may need it. Is it the answer to your question?
Yeah, that's my understanding. That you need sometimes some up support for these lung constructs.
Right. Exactly. Okay. Thank you, everyone, for listening and asking questions.
Any questions?
Professor Zileli, I have a question for you. What's the percentage of cases of the C1 assimilated cases in your hospital?
C1 assimilation.
What's the percentage?
I didn't count, but the percentage you ask, the ratio.
Yeah.
Probably 20% or 20, more than 20%.
20%. But in our hospital, about 90%.
90%?
Yeah, the patient we meet, we treated this kind of patient in our hospital.
You use C1 screws only?
If there's no C1 assimilated, we will use C1, C2 fixation. If there's C1 assimilated, we use C0 to C2 internal fixation.
In case of assimilation?
Yeah.
Okay. But, okay. Thank you.
What about in condylar hypoplasia?
Yeah. It is also another indication for that. Condylar hypoplasia. And actually, we must always get good CT scans before surgery and see the screw trajectory and also the vertebral artery trace.
Do you think the navigation system is useful for this kind of a case?
Navigation?
Yeah. We have.
It may be, but I don't have it.
Okay, so
it may be useful, yes.
Yeah. So shall we